Good evening, and thank you so much for joining me. I entitled the presentation About Face Management of Thoracic Trauma in 2022. As the last 2 or 3 years have really challenged the dogma in terms of the management of thoracic trauma, both blunt and penetrating. And I had started this presentation in, I think, late November or early December. And the December 2021 and January 2022 Journal of Trauma and Acute Care Surgery have really put a lot more literature into the spotlight on these topics. So I was excited to include them on this. And again, thanks so much. Let's get started. I have nothing to disclose. Objectives. We'll talk about which pneumothoraces require intervention, how to manage a routine hemothorax, times where you don't want to rely on thoracic ultrasound, and talk just a little bit about some of the options for management of thoracic trauma, more just out of interest than anything else. So what are the immediately life-threatening chest injuries? This is taken right out of the ninth edition of ATLS presentation, and then I added in what the interventions are that successfully manage most of these injuries. So laryngeotracheal injury or airway obstruction, you've got to clear the airway, get these folks intubated, or if you can't intubate them, perform a surgical airway, whether that be a cricothyroidotomy or tracheostomy, depending on the location of the injury. Tension pneumothorax, we'll talk about some of the disadvantages of needle decompression and why initially a finger thoracostomy followed up by a tube thoracostomy is ideal. Open pneumothorax, we'll also touch on this and why the management of these injuries alone is generally not the life-threatening problem. Flail chest and pulmonary contusion. These things are much less likely going to be, quote, immediately life-threatening, but they can develop into some severe problems. Massive hemothorax, initial management is going to be with tube thoracostomy and then cardiac tamponade. There may be some role if you're not equipped to deal with this surgically for pericardiocentesis, but ultimately the management is going to require surgery. So I had started this slide earlier last month, and there are several papers. 2019 paper looking at this 35 millimeter rule, which has been talked about quite a bit, and especially in blunt trauma, and then the subsequent validation of observation of the cold pneumothoraces in penetrating trauma. But then the West algorithm for management of traumatic pneumothorax came out last month, and we'll talk about that on the next couple slides. So we'll talk about how to manage 35 or how to measure 35 millimeters. But basically, it's now been validated in both blunt and penetrating trauma. This 2019 paper looked at it in non-intubated patients without hemothorax in both blunt and penetrating trauma. There was a slightly increased rate of failure, about 10% of patients required a chest tube in penetrating trauma and 8.7% in blunt trauma. Beatty et al., they looked at occult pneumothoraces, so visible on CT, but not on chest x-ray. And 18% of those patients went on to require a chest tube. They were higher risk if they were on positive pressure ventilation, that it can concomitant hemothorax, routine bullet, or chest AIS greater than 4, which you're not going to know at that time. If the title of the article is not in the slide, it's listed in the notes below and will be available on the uploaded copy of the presentation in Box. So all of the references are there. Feel free to view them yourselves for all of the slides, and then reach out and I'd be happy to discuss these further. So then, as I said, the West algorithm. So in an unstable patient with a pneumothorax who you think the pneumothorax is causing their hemodynamic instability, they should get a chest tube. They should also get a dose of periprocedural antibiotics, which is normally going to be a single dose of Ansep. If you don't have a tube with you, a needle, a decompression, or finger thoracostomy, which just means you make your incision, you dissect down, go into the pleural space, and stick your finger into the chest. That confirms that you have reached the chest, and that should adequately evacuate any tension. Tension can reaccumulate, and you may have to put your finger back in, or in the case of a needle decompression, use a second needle, and then ultimately you want to get the chest tube in. However, for patients who are hemodynamically stable, if it's clear on the initial chest x-ray that the pneumothorax is greater than about 20%, you can go ahead and place a chest tube at that time if you want before you go to CT scan, because ultimately that patient's going to wind up requiring a chest tube. If you are going to go to CT scan, we'll talk again about how to measure this 35 millimeters. And if it's greater than 35 millimeters, you should place a chest tube. And if it's less than 35 millimeters or less than 20%, you should repeat the chest x-ray in 6 hours. You can do this on patients on positive pressure ventilation or not on positive pressure ventilation. Remember, observation is not no treatment. You're getting an x-ray, and if it gets worse, you go ahead and place a chest tube at that point after giving periprocedural antibiotics. All right, so this was a nice review of point of care ultrasound. You do your EFAS, the 4 views, 3 in the belly, 1 of the pericardium, and then you get your 2 cardiac views. So this is M mode down below. Up top, you see the pleura as denoted by the red arrow, and then you see different areas of we call it the seashore sign and the barcode sign in areas where you have pneumothoraces and no pneumothorax. So the issue with ultrasound is that it only shows you if there's a pneumothorax where you're holding the probe. It doesn't evaluate the whole chest cavity. And so you have to check in multiple places. How do you measure? So this is measure radially from the parietal pleura to the visceral pleura. You're going to scroll up and down the CT to the area where that distance is the greatest, and then measure it. And if it's greater than 35 millimeters, their likelihood of failure is relatively high, and you can go ahead and place a chest tube. We don't talk about a concomitant hemothorax because you may place the chest tube for hemothorax, even though the pneumothorax component is smaller than 35 millimeters. So that's why the rules for hemothoraces and pneumothoraces are kind of developed in isolation, because there is you don't know in those studies if you're placing it for a hemothorax or a pneumothorax, and it can get a little bit confusing. So in the patients with combined injury, you just have to um, combine those two rules of thumb, and we'll talk about the hemothorax rule of thumb in a couple minutes. Should you use antibiotics for chest tube placement? Probably yes. Why is there no um, article on this page? Because there's multiple studies, randomized trials, multi-institutional studies looking at it, and some of them are equivocal, some of them do demonstrate a benefit, but we look at things in terms of a risk-benefit ratio. And one of the things that I was unable to find when I was making this presentation is what is the risk of a single dose of ANSEF in terms of risk of an allergic reaction or risk of C. diff or risk of creating a resistant pathogen. And I couldn't find that data, so how one could make a risk-benefit ratio, I don't know. What we do assume just anecdotally is that that risk is exceedingly small, and that if there's even a small risk of empyema, that it probably is reasonable to give a single dose of antibiotics. Really interesting study out of the Denver group looking at chest tube placement, different complications, early and late complications. So late complications basically were people who had to undergo VATS or thoracotomy in a delayed fashion for a treatment failure. And so they looked at a whole bunch of chest tubes, who put them in, where they wound up, additional interventions that were required. So on the chart on the left, you'll see that 294 tubes did not have any malposition, but 157 did. And then the double asterisk is highly statistically significant, single asterisk is statistical significance. So if you look at deep placement, basilar placement, fissure placement, kink tube, extrathoracic side hole, shallow placement, subcutaneous, and intra-abdominal, the percentage on the left is how often a late complication was associated with them. So that would include tube reposition or tube replacement. So if you had a subcutaneous chest tube or an intra-abdominal tube, you have not drained the thorax, and so 100% of the time those have to be replaced. But the rate is also extremely high for a kinked tube because it's not draining. A deep tube or basilar placement. But then how often do these matter? If you have a tube that's in the fissure or at the base, is it actually doing its job? So then they looked at how many of these tubes were associated with early complications. So 103 of the tubes were associated with early complications. The most common ones being, correction, not the most common ones, but the numbers on the right of the right-sided chart demonstrate the percentage of developing a late complication. So patients with a residual hemothorax or requiring another chest tube had a higher incidence of late complications. And then basically nobody with a lung injury or solid organ injury. So it does matter where you put the tube. Maybe not every time, sometimes you get away with it. But one of the most simple things is getting it so the side hole is in the chest, that it's not kinked, that it's not deep. Sometimes, whether it's in the fissure or not, or whether it goes basally, those are more variable. But in almost all patients, putting it to the 10 to 14 centimeter marking, and I would argue that you should err closer to the 10 because you might run into trouble with a smaller patient, is going to prevent that tube from kinking. And it's going to prevent the side hole from being out. So if you don't know how chest tubes are measured, there's an angled tube on the right and a straight tube on the left, and it's measured from the tip of the tube to the sentinel hole, and that's where the break in the radio opaque marker is. It doesn't matter if it's curved or straight tube. And the numbers start from the sentinel hole. So whatever the marking is, it's plus 8 centimeters, and that's fairly consistent across different manufacturers of tube. So this is just a chest X-ray from a patient. I did a VATS on. They have their basilar tube, which don't worry about. You shouldn't put a tube that low. We did it under direct visualization, as close to the diaphragm as we could. And then I measured, this is straight kind of as the crow flies, there's a little curve to it, but from the sentinel hole to the skin edge is 11.3 millimeters. I made it, 11.3 centimeters from the sentinel eye to the skin. And so if you add in a little bit extra for the curve, maybe you say 12 centimeters. So that'd be the 12 centimeter mark. And then it has 8 centimeters from the tip to the sentinel eye. So about 20 centimeters from the skin in. And this is a full-size adult male. So you could see that if you weren't doing it under visualization, it might even be a little too much, and that 10 centimeters would leave plenty of distance from the skin edge to the inside of the thoracic cavity. But this would eliminate a lot of the complications discussed on the previous slide. This is a very common thing that we see on tubes placed here at Barnes. Then, of course, what size chest tube should you put in? I won't belabor this, but basically there was not a difference between a smaller chest tube, a 28 or a 32 versus a 36 and 40. Pretty much use 28s for everything. They don't have higher rates of requiring a second tube or lytic therapy or image guided tube placement, VATS or thoracotomy. And some studies show that there's decreased pain from decreased pressure on the intercostal nerves. So I try to always use the 28, except my lower tube on VATS usually is a 24, but that's not part of this study. So chest tube management here at Barnes, if you're not familiar, we have a protocol, or a guideline, I should say. So you put in the tube, it should go on 20 centimeters of water suction. Every day you should do a physical exam, look for an air leak, look how much came out, and the character of what came out, and get a chest x-ray. If there's a pneumothorax, output's greater than 200 centimeters, there's an air leak, or evidence of a retained hemothorax on chest x-ray, then it should just stay on suction and you reevaluate it. If none of those 4 criteria are met, it should go on water seal. After 24 hours, you repeat a chest x-ray and a physical exam. And if none of those criteria are again met, the tube should be removed. And then you get a 4-hour post-pull x-ray. If after 72 hours you haven't made any progress, the patient should be evaluated for VATS. So do we need a post-pull chest x-ray? So this was a meta-analysis that looked at 7 studies for a total of 1,200 chest tubes. About 20% of the time there was a positive finding on the post-removal chest x-ray. 70% of those were pneumothoraces. And 45% of patients with a positive finding underwent re-intervention was most commonly replacement of a chest tube. 2/3 of the time and 1/3 of the time was a thoracotomy or VATS. Most of those studies did not include if the patient developed symptoms at the time of removal or at the time of the x-ray. This flow sheet here, though, looked at a subset of 220 tubes where all of those patients underwent chest x-ray. 197 of them had a negative chest x-ray, 22 patients had a positive x-ray. 6 of those patients developed symptoms, and all 6 of those patients underwent reintervention, and there was no reintervention in the 16 patients who had no symptoms. 1 patient had symptoms and a negative chest x-ray, and no intervention had occurred. So this begs the argument, do we actually need the chest radiograph, or can we just monitor the patient closely for symptoms? This would suggest in this small subset that you could. The biggest problem being the amount of time that it takes to get a chest x-ray here is very long, so it would be nice to know that information in advance. Hey, there is a pneumothorax if that patient develops symptoms, put in a chest tube, or B, if you're going to discharge that patient, you can be reasonably reassured if that x-ray is normal that they're not going to be that they're not going to require an intervention if they develop symptoms. This was the 2020 East Guideline was actually published in 2021, looking at guidance for retained hemothoraces. Question 1. In a hemodynamically stable patient with a traumatic hemothorax, which they define as less than 500 milliliters, should you routinely drain these, or can they be observed? There's no recommendation. The data was confusing because there was some studies with a threshold of 300 milliliters and some with 500 milliliters. However, I think most people use an approximately 300 milliliter cutoff, and you just multiply the length times width times height on the CT, because 1 cubic centimeter equals a milliliter, to estimate the size of the hemothorax. So this 2012 East MCT is probably the best thing that we have, and the strongest predictor of successful observation versus requiring an intervention, such as the chest tube, VATS, or thoracotomy, was volume of the retained hemothorax greater than 300 milliliters. However, you also need to take this with a grain of salt, because patients underwent this at the discretion of the surgeon or whoever was caring for the patient. We don't know if those patients who had, let's say, 400 milliliters would have gone on to develop a fibrothorax, entrapped lung, or an empyema, which would be the 2 biggest concerns of a hemothorax. Because they underwent intervention. So was that intervention necessary? The jury is still out on that. And then just theoretically, penetrating versus blunt, patients who have a blunt injury, unless you have an open pneumothorax, if you don't undergo chest tube placement, you would think that your risk of empyema would be relatively low because there's no violation of the chest cavity, whereas in penetrating trauma, by definition, there's violation of the chest cavity. Question 2. In a hemodynamically stable patient with traumatic hemothorax requiring drainage, should pigtail catheter 14 French or smaller versus a thoracostomy to be placed? They conditionally recommended use of the pigtail catheter. If you look at the upper forest plot, the rate of retained hemothorax is favors pigtail catheter, but still crosses the one. Um, and then if you look at the need for operative intervention or second tube, um, it does support placement of a pigtail. However, most of these studies were done at University of Arizona. So unless you're a wildcat and you do a lot of these, it might not be as beneficial. Um, there's definitely potential harm going through the diaphragm, going into the PA, and things of that nature. So if you do them, you have to be really careful. I always use ultrasound guidance um, when doing it for a retained hemothorax. Um, and that's generally speaking not our standard here, and not particularly strongly supported by the evidence or this recommendation. Lytic therapy versus VATS, usually it's a combination of TPA and ordinase alpha. You see that there's conditionally recommending VATS over thrombolytic therapy, and there's a non-statistically significant favoring of VATS in terms of need for operative intervention. However, hospital stay is quite a bit shorter in the VATS population. If you think about this, if you fail thrombolysis and you go on to VATS, that's going to take a lot longer, and also staying in the hospital to get several days of lytic therapy, like between 3 and 5 days in most studies, is going to take a lot longer than it would to post the patient for the OR, take them to the OR later that day or the next day, clean out their chest, and hopefully get the tubes out over the next couple days and send them home. So the actual strongest recommendation in this guideline is really for in a hemodynamically stable patient with a retained hemothorax that you think is going to require surgical intervention. Should you do it less than or equal to 4 days or greater than 4 days, which is what they termed early versus late. Strongly supported early. It didn't really change the need for additional pigtail catheter or thoracostomy tube, but did decrease the rate of conversion to thoracotomy, risk of empyema, need for additional procedure, hospital length of stay, ICU length of stay, number of days on the ventilator, and inpatient mortality. So if you recognize a retained pneumothorax, you should get them to the OR basically as soon as you think the tube is no longer draining the hemothorax. So if you put it in today, I would say by tomorrow, if not the day after, your chest x-ray doesn't look good, you can go ahead and do a non-con chest CT and see if there's a big retained hemothorax, and then put them on the next day. So within 72 hours, you could really make this determination. It's unlikely that what doesn't come out initially is going to come out over the next few days. And I thought this study was fascinating. This is from UCSD. They have pioneered this CUST exam, which is actually a comprehensive ultrasound in trauma. It's done by a certified ultrasonographer and read by a radiologist. It's far more comprehensive than a FAST or an EFAST. And they've actually published about the sensitivity being essentially equivalent to a CT scan for abdominal trauma, which I find interesting. But they then went back and looked at the detection of pneumothoraces versus chest x-ray. So they started with 362 patients who were found to have a pneumothorax. They threw out cases where it was an occult pneumothorax that had to have been seen on the chest X-ray or the ultrasound um, in order to be considered a non-occult pneumothorax. So there's 171 of the remaining patients. The sensitivity was 78% on chest X-ray versus 65% on ultrasound, which was statistically significant in support of X-ray. And there was a 35% false negative rate with ultrasound. So if you think clinically that somebody has a pneumothorax, a clinically significant pneumothorax, and the ultrasound is negative, you should probably go ahead and put in that tube anyway. And I can't imagine a better way to conduct this study other than just with more patients. But this is a certified sonographer being read by a board certified radiologist, and the images are retained. Um, and these are clinically significant pneumothoraces that are being missed. 50% of them went on to require an ultrasound. I'm sorry, a chest tube. And then while we're talking about fast exam, an important note about false negatives in the pericardial fast. A false negative, a positive pericardial fast, um, regardless of the scenario, unless they have a known pericardial effusion, should be considered positive in all situations. But a negative pericardial view in the presence of a hemothorax um, lacks sensitivity. The idea is that a pericardial laceration can drain blood into the hemothorax and you won't build up hemopericardium and you won't see it on fast. So this is on CT. A patient had a negative fast, and then on CT you can see that there's an RV perforation draining into the pericardium, and then there's a pericardial laceration draining the hemopericardium into the right chest. There's quite a few case reports of this, and then probably the largest series out of Grady, looking at 228 patients who underwent a fast. And these are patients who underwent multiple fast exams. Most of the patients underwent 3. Some of them underwent 2, who had penetrating pericardial trauma or precordial trauma. 37 of the fasts were positive and had emergent sternotomies. And then 5 patients had false negative fast exams. Several of those patients who had left-sided injuries died, and the patients with right-sided injuries were generally identified in a delayed fashion and repaired in the operating room. So the only way to rule this out, CT is helpful, obviously, if you can exclude the bullet tract from anywhere near the heart, but with a high velocity bullet, this may also be falsely reassuring because of the blast effect. So the only way to truly rule this out is with a pericardial window. Rib fractures, pretty much what we'll talk about for the rest. They're very common. They comprise about 10 to 26% of blunt trauma. They're present in 10 to 26% of blunt trauma patients, and they comprise about 10% of all admissions for the trauma service, which is a really significant number. They're very common, seen in tens of thousands of patients annually in this country, and they comprise over $450 million of healthcare spending, which is only getting higher, and that spend is higher in patients with flail chest and multiple fractures. So age is an important factor. You know, the thing on the rib score that gets you the most points, lands people in the ICU the highest, is age. The original study from 2000, I think, with Bolger um, et al. Used an age of 65 as a cutoff, and then I think 15 to 65. Um, and that's displayed on this chart on the right. And you can see that complication rate is much higher. They had also demonstrated that there's an increase for each additional rib fractured, but really the point of inflection is at 4 rib fractures. This was substantiated looking at the Memorial Hermann data by Holcomb, but they found their point of inflection for age at age 45. And there's some other data looking even at age 40, being at higher risk for negative outcomes, but also identified 4 fractures as an inflection point. And then it's one thing to talk about mortality, but we don't just want our patients to survive. These are often young folks with jobs. We want them to thrive. This was looking at patients at Stanford. They used the trauma quality of life score. It's 43 questions. Unfortunately, they didn't have any comparison group for this. It's one of the first uses of this validated scoring system in this population. But basically, they took all patients and then patients with isolated rib fractures and compared them. So, not surprisingly, patients who had an AIS greater than 2 in an extrathoracic area had a little bit lower quality of life. And they looked at, at 5 main areas as listed on the left, and 4 is the best score. And you can see that even at 3 months, none of these even come close to reaching 4. And really, the physical well-being is quite low, and that there's minimal improvement from the 1 to 3 month post-discharge period, which one would expect to be a period of rapid healing and improvement. A couple of nice studies by Silvana Marasco rather, from Australia, who's a cardiac and thoracic surgeon there. Lots of work on quality of life as well as rib fracture fixation. So looking at flail chest, this was the short form 36 quality of life, and this was at 6 months. The patients who underwent surgical stabilization for rib fractures and did not had no difference in their quality of life. However, the quality of life to which they returned was much lower than the baseline for the Australian population, which in all of these metrics should be essentially around 50. And you can see that there's like low and mid 30s, and this was 6 months post injury. The same group looked at 24-month quality of life impact. This was using 3 different scoring systems. And they looked at roughly 400 patients. Patients who underwent surgical stabilization for fractures were excluded. And then they created a thoracic group who had mainly thoracic injuries, and then a multi-trauma group who had an AIS greater than 3 in the chest and an extrathoracic AIS greater than 3. In both these groups, only 71% of patients who were working at the time of their injury had returned to work, which is remarkable and demonstrates the severe morbidity of thoracic trauma. And then, so looking again at these folks, again, this is 2-year outcomes. You can see that short form 12 at 6, 12, 24 months, as well as pain scores, and then the Glasgow scale, the Glasgow outcome scale at 6, 12, and 24 months. What you'll find here is that for a few of the outcomes, the thoracic group did a little bit better than the multi-trauma group, but for most of them, there was no significant difference, meaning that the thoracic injuries are really driving the lower quality of life and the morbidity, and that these numbers are all significantly below the Australian baseline quality of life and pain standards. Again, meaning that these patients are not coming anywhere close to meeting their baseline, and that there's really little to no improvement from the 6 to the 24-month, meaning that they're not continuing to improve. So if they're not good by 6 months or potentially earlier than that, based on the study from the previous slides, they're really not getting better with time, and that's very concerning. So we talked about that huge cut point at 4 ribs, but what about just a single fracture? This was presented at AAS last year, looked at and published this year, looked at the 2016 National Inpatient Sample. They actually used it to create a predictive scoring system, which is why there's a training set and a validation set. But in patients who had a single rib fracture, the tracheostomy rate was almost 3%, pneumonia in about 13%, length of stay greater than 12 days and 7%, 2.5% of the patients died, and basically 21% of the patients had some form of morbidity. So even a single rib fracture, very significant. I'm not going to talk so much about what to do for the rib fractures as to just be aware. We were pretty good about multimodal analgesia here, really reducing opioids, early epidurals, early paravertebral catheters, lidocaine drips, things like that. One of the things you can do at the time of surgery for surgical stabilization of rib fractures, or this could be done even without it, but that's pretty uncommon, is to do intercostal cryoablation. So you actually create a lesion close to where the intercostal nerves are coming out of the spine and numbing that area for a period of generally months. You really can't do this on lower ribs. I wouldn't do this below about the 8th rib because you can denervate the obliques and patients can develop some muscle bulge there. And this is the same system, the AtriCure system, that they used to create the lesions for Cox-Mees procedures for AFib. So it's available here in the hospital. On the left, you're seeing the chest from the inside. The rib is to the left, and the arrow is pointing at the neurovascular bundle. Remember, vein, artery, nerve, and then you create the lesion for 2 minutes at each intercostal level. The different probe is being used on the right side. This is extrathoracic. You can see the rib plates in position, and basically you can try to stay extrapleural, but you slide the probe underneath the rib and create your lesion again for 2 minutes at each rib level. Study this year in the Journal of Trauma, looking at 136 patients with rib fractures. 92 patients had rib plating only, and 44 had rib plating and cryo. There was a decreased length of stay from 10 to 9 days in the group that underwent cryo. Post-op length of stay 4 versus 6 days. 89 versus 114 morphine milliequivalent estimated daily dosing. During the hospitalization, there was no difference in hospital charges. However, the post-op charges were lower in the cryo group, which makes sense because their length of stay was lower. So decreased opioid use, decreased length of stay, The downside of this is that the probe costs about $2,000 and it's not considered a separate procedure, so the hospital doesn't necessarily get separately reimbursed for that, depending on the type of insurance. Sternal fractures, we don't have great data about who you should fix, but basically people with persistent pain, clicking, if the sternum itself is impinging on the mediastinum or the heart, that would be a strong indication. And then these injuries are frequently associated with thoracic spine fractures. And depending on the fracture pattern, there may be some concern of further displacement of the fracture at the time of spine surgery. So sometimes you'll fix the sternum prior to flipping them over for the spine procedure. But again, there's no strong recommendation, so we won't cover this heavily. Needle decompression, we promised we'd talk about it. Highly unreliable, regardless of if it's at the second intercostal space midclavicular line or the fifth intercostal space anterior axillary line, as most people are now recommending. This was a study out of Vandy, 10 years, 335 patients who underwent chest CT and needle decompression. Some of them had bilateral, so there's a total of 344 hemithoraces. And 76% of the time, the angiocath didn't even reach within 5 millimeters of the pleural space. And 39% of the time, the patient had no pneumothorax on CT. So unlikely you put the angiocath in and didn't cause a pneumo, or that they didn't have a pneumo to begin with. And then they had also taken a bunch of measurements to evaluate the anterior axillary line versus the second intercostal space midclavicular line. And while the distance was shorter at the fifth intercostal space, a lot of the new catheters are 3.25 inches, which is 8 centimeters, including the one I've pictured here. And then they found that 8 centimeter catheter would actually reach the left heart border in 48% of patients. So they do recommend caution when placing it at the fifth intercostal space. Open pneumothorax. Basically, when you do a needle decompression or finger thoracostomy, you're creating an open pneumothorax. So there's often this obsession with getting an occlusive dressing on, but generally you only see this deranged physiology of the inability to generate a negative inspiratory pressure when the size of the defect is about 2/3 of the tracheal area. And there's different ways that you can fix that. If you already have a chest tube in, you just occlude it and then you prevent tension by using the chest tube. And that's the ideal scenario. If you don't have a chest tube in and don't have the ability to place one, you can put in a 3-sided occlusive dressing. And then lastly, you can intubate the patient, put them on positive pressure, and then you don't have to worry about generating that negative pressure. Just very briefly about tracheobronchial tree injuries. However, you can get the tube into the distal airway, and then we'll worry about a creative strategy with the endotracheal tube or with bypass or ECMO to keep the patient oxygenating and ventilating while it's repaired. But the immediate thing is to get them oxygenating and ventilating adequately. So sometimes you can actually put the tube in through the wound. You can free up the trachea and make it mobile, cover a couple centimeter gap, which is what they're demonstrating in this picture. You should suspect a tracheobronchial tree injury with a massive air leak. Sometimes the patient will get worse after the chest tube is placed, and it still doesn't improve despite placement of a second one. you should do an early bronchoscopy. And most of these injuries are located either in the trachea or within 2 centimeters of the carina. A tracheotomy is just a cool thing. Sometimes if there's a big air leak or a lot of bleeding from the lung, you basically shove a stapler through it or 2 clamps through it. And you can open the lung up and then oversew it. Some of these procedures require lung isolation. Classically, the dual lumen endotracheal tube is a left-sided endotracheal tube because the takeoff of the right upper lobar bronchus is very proximal and makes it very difficult to position a right-sided endotracheal tube. But depending on where that tracheobronchial tree injury is, you may require a right-sided tube. So I know some of our colleagues are not familiar with these. Obviously, most anesthesia folks and surgery folks are, but. And then I just found this page, awesome, where to cut. This was from an article in the Surgical Clinics of North America. And depending on which site you suspect the injury to be is where you're going to make your incision. Unlike in the belly where you make a laparotomy for everything, you have your choice between a sternotomy, a right thoracotomy, and a left thoracotomy, and really there's anterolateral thoracotomy, posterolateral thoracotomy. And so this just demonstrates whichever structure you're trying to access. Some are good, some are okay, and some there's no access to at all. And then I'll try to show this video in a minute here of a case from the other day. What incision would you use? And then in summary, many thoracic injuries can be safely observed. However, not intervening on those that cannot be observed is often fatal. Simple interventions are life-saving, but you have to be able to do them correctly. And then chest injuries are a source of persistent morbidity, as we talked about in the rib fracture patients. And it's unclear which interventions we can do to improve the quality of life in those patients. Thanks so much, and I'd be happy